A neat graphic depiction of what happens with obstructive sleep apnea is shown here. The sleep apnea patient falls asleep very shortly, and usually during REM sleep this will happen. There's a loss of airway tone, then all of a sudden the airway becomes obstructed, and then hypoxia occurs, hypercapnia occurs, acidosis occurs, and all leading to what you have on the right side here: arrhythmias, systemic hypertension, chronic hypercapnia, pulmonary hypertension, and cor pulmonale. It's very interesting if you've seen a video of a person in a sleep laboratory, what they look like. They're actually struggling to breathe. They look like they're actually suffocating. And as a result of these suffocations, there can be arousals. The body doesn't know what to do to make them breathe except to cause at least a partial arousal to have them start breathing again. Now, this will increase the airway tone, the patency of the airway, and then the patient will start breathing, and the whole cycle starts all over again. Now, as a result of the arousals, this is called fragmented sleep. And this fragmented sleep will cause the hypersomnolence and impaired cognition, the brain just not working well. And so we can see here a graphic depiction of why these consequences occur, of not just the sleepiness and impaired cognition, but also the arrhythmias, hypertension, and other cardiovascular issues. So to summarize the consequences of obstructive sleep apnea with respect to morbidity, we can see here that with the odds ratios, there's hypertension, coronary artery disease, congestive heart failure, stroke, but also there's cognitive impairment, which causes the motor vehicle accidents we talked about, and even industrial accidents. Depression can also occur, as well as diabetes and metabolic syndrome in obstructive sleep apnea patients. Now, the consequences with respect to symptoms. We talked about these earlier, and the main one is excessive sleepiness. It's the major presenting complaint. But interestingly, keep this in mind, that the great majority of patients who have obstructive sleep apnea won't complain of sleepiness at all. So we have to be on the lookout for other symptoms that they can come in with. We may want to ask them about snoring, or the bed partner may actually complain about snoring. But be on the lookout for nocturia or even plain bedwetting. A patient who complains of night sweats. Doc, I wake up in the middle of the night and I'm drenched in a cold sweat. Morning headaches. The patient who comes and says, you know what, when I get up in the morning, I've been getting a lot more headaches lately. It goes away pretty quickly, but I get them every morning. And this is the patient that has hypercapnia when they wake up. A sore throat or a dry throat. Hey, doc, I get a sore throat all the time. What's wrong with me? Trouble concentrating. The person who says, you know, I'm not as sharp as I used to be. Or the mood and behavioral changes, irritability and depression, oftentimes brought in by the bed partner or by a friend or a relative. And finally, keep this in mind, gastroesophageal reflux is much more common with obstructive sleep apnea. So when a patient has reflux, be on the lookout for the possibility of obstructive sleep apnea. Now, a very interesting correlation has been found between psychiatric disorders and obstructive sleep apnea. This is a very large Veterans Administration database study, looking at all the patients with obstructive sleep apnea and what psychiatric conditions they had, and also just the other way around, all the patients with psychiatric disorders and how many of them in fact had obstructive sleep apnea. And it turns out that patients with obstructive sleep apnea are much more likely to have psychiatric disorders like depression, anxiety, post-traumatic stress disorder, psychosis, and bipolar affective disorder. And interestingly, those who were diagnosed with obstructive sleep apnea who were treated, their depression actually was less in amount. So this kind of hints at the notion that when we treat obstructive sleep apnea, we can lessen depressive symptoms. More of this to follow later on. Complaints of obstructive sleep apnea for men and women differ. Men have a tendency to say things like, I'm tired, my memory is bad, and I don't have energy, and much less likely to say, hey doc, I'm sleepy, I feel as if I haven't slept well. Women, on the other hand, will correlate with saying, I'm sleepy. That is, I feel pathologically sleepy or excessively sleepy throughout the day. They'll also say that I have trouble sleeping and insomnia. Again, women seem to have much more of an astuteness towards their sleepiness versus tiredness issue. Interestingly, women that have obstructive sleep apnea are more likely to have depression and hypothyroidism. One of the things that we like to stress about patients and sleepiness and sleep in general is, what does their bed partner say? It's very important to have bed partners give you information. For example, what they can complain of is loud snoring with their partner, witnessed apneas, restlessness in sleep, and personality changes. So it's always a good idea to, at some point, query the bed partner about how the patient is doing with respect to their sleep. A very good tool for you to assess the level of sleepiness in your patient is called the Epworth Sleepiness Scale. Now, in this validated instrument, an 8-point questionnaire, the patient is asked how drowsy they are in these passive situations: sitting and reading, watching television, sitting inactive in a public place, as a passenger in a car, lying down to rest in the afternoon, sitting and talking to someone, and sitting quietly after lunch, and in a car while stopped in traffic. The patient puts down 0 to 3, and you add it up. And a number greater than 10 is pathologic drowsiness. That is, when a patient has a level of 11, 12, or 13, you can quantify that this patient has excessive sleepiness. Let's now look at the risk factors for obstructive sleep apnea. We've talked about the symptoms of obstructive sleep apnea. Now let's look at what the patient looks like that comes into your office that you should have a higher level of alertness to the possibility of obstructive sleep apnea. The risk factors include obesity, being male, advancing in years, alcohol. Perimenopausal and postmenopausal women have a higher rate of obstructive sleep apnea than premenopausal. Their rates equal that of men. Black race and smoking, but also family history. These are all risk factors for obstructive sleep apnea. When you look at a patient, if you see several highlighted items, it should increase your thoughts about the possibility of obstructive sleep apnea. The patient sitting across the table who seems to have a large neck size, quantifying men greater than 17 inches, women greater than 16 inches. This person has a higher probability of obstructive sleep apnea. Also, the way that their mouth and facial features are, micrognathia, for example. And another one, when you look at the throat, something called a crowded pharynx. You look in there and you see very little room for air to go through. Or even higher up in the nasal cavities, nasal obstruction. Think of the possibility of obstructive sleep apnea in these specific physical findings. There has been found a correlation between certain types of throats, which is called a Mallampati scale, and obstructive sleep apnea. You can see here graphically from class 1, 2, 3, and 4, what's happening is the amount of airway is decreasing. On average, then, the odds of having obstructive sleep apnea increases more than twofold for every 1 point increase in Mallampati scale. It's a very important way, then, of increasing your level of alertness to the possibility of obstructive sleep apnea just simply by looking at a patient's throat. So when we add this all up, when should you suspect obstructive sleep apnea? Obviously, not every patient that comes into your office that you should ask them for the possibility of obstructive sleep apnea, but especially think of the patient that has comorbid conditions as we described above. Also, when a patient has physical findings like we talked about, and finally the symptoms as we described. So if a patient comes into you with no symptoms of tiredness or whatnot, but they seem to have a large neck size, or they are overweight, or they have a family history of obstructive sleep apnea, this person should be queried about the possibility of obstructive sleep apnea. So what do you do? What do you ask? How to get at the possibility that obstructive sleep apnea is occurring in this patient? As we said, look at the family history, but after that, ask, do you feel sleepy during the day, and do you snore? And please keep this in mind. When you say sleepy, you have to actually probe that you ask the patient, do you get drowsy in passive situations? I like to sometimes ask a patient, if I were to turn the light off in this room and leave and come back in 10 minutes, what's the chance that you'd actually be asleep? Patients will sometimes say, oh, sure, doc, I'd be asleep in a couple of minutes. That's my way of sometimes assessing how sleepy a patient is. As far as snoring, please also keep this in mind. We discussed this earlier, that the bed partner should be asked because oftentimes a patient who snores just doesn't know they snore at all. One guideline that I'll suggest to you about referring to sleep laboratory. Any patient who comes in with gasping or choking, witnessed apneas, please suggest that this patient go to the sleep laboratory. To me, this is no different from somebody coming in saying, hey, doc, I get chest pain when I exert myself, and I get shortness of breath, and as soon as I stop, it goes away. I send that person to get a stress test done. Similarly, we should say the following with obstructive sleep apnea. Choking, gasping, witnessed apneas equals a sleep laboratory. But also, snoring and one or more of the following. Insomnia, excessive sleepiness, BMI greater than 35, large neck size with men and women as we discussed above, and a Mallampati score, especially at 3 and 4, and finally some comorbid medical conditions, especially hypertension and especially resistant hypertension. Think of referring these patients to the sleep laboratory.